Well, thanks for having us, everyone. Also, a big thank you for being one of our CGM training pilot sites. I think those of you guys who were involved with the pilot will hopefully be pleased with some of the additional work we put into some of the pain points in the CGM pilot. But why don't we go ahead and get started? So I think I know most of you. My name is Crystal Wong. I am a family doctor. I work at Ravenna. I'm also the Associate Chief Digital Health Officer. And we also have Mika Mäkinen with us today. Mika, do you want to introduce yourself?
Sure. My name is Mika Mäkinen. I'm a project manager for the telemedicine team, and it is my pleasure to be here with you guys today.
Yeah, and a lot of you guys might know Mika at his previous life when he was the manager at Smoky Point when we still had that clinic. So today we are going to be providing the provider-centric training for the CGM program that's actually live at most of our clinics now. You guys are in phase 3, which is the last phase to go live. Please feel free to unmute and ask questions if they come up, or put things in the chat. I'll have Mika watch the chat since I'm not that great at doing that and talking through the slides. He can interrupt me at any point to ask any questions from the group. Also, just a reminder that we are recording this, and so if you want to watch it again, or if any of your colleagues aren't here today, they can watch that. Okay, so let's start with the basics. What is remote patient monitoring? And I think all of you guys know the answer to that, but remote patient monitoring is using a device to remotely collect and send data for interpretation. And in this case, we're going to be talking about continuous glucose monitoring, which is a way for a patient to use remote monitoring to take care of their diabetes. RPM allows us some really unique opportunities, really bringing medicine into the patient's natural environment, into their home environment where, you know, the majority of life is lived out, the majority of choices are made, et cetera, as opposed to forcing everything into that clinic visit, which we know is really just kind of a minimal amount of time to really see what the patient's, social determinants of health are doing for, in this case, their diabetes. We do hope that with wider adoption of home monitoring and really providing care to patients in the home, that will, decrease some of the in-person time and reduce maybe number of visits, helping us with a higher efficiency healthcare system. You can go to the next one, Mika. So this is what we're going to be covering today. We're going to talk through the workflow, specifically through the provider workflow. And part of the workflow is identifying patients, outreaching to patients, consenting patients, and enrolling patients. We'll talk a bit about the data submission and upload and use of these devices. We'll talk about interpretation of what are called AGP reports, or ambulatory glucose profiles. We'll talk about facilitation of care, how you're going to communicate with your care team members. And then we'll talk a little bit about coding and billing, as well as give you guys some good resources. You can go to the next one, Mika. Thank you. This, I'm not going to go into huge detail, but this is a video that we put together actually for the pilot CGM project. And one area that we actually worked a lot in and put in a few more slides. So if you guys have the old documents for some reason from the pilot, this part of the flow sheet right here that says in the provider swim lane, there's this green arrow and a red arrow. This is all about payer coverage. This is all new. And the patient prior auth team, the same that do PAs for pharmaceuticals, will be supporting this workflow. That was one area that was, we got a lot of feedback from the nurses and dietitians during the pilot about, just streamlining that and putting a little bit more infrastructure to help patients get coverage. And we are going to spend a bit of time talking about coverage for devices because that is one of the kind of pain points and doing RPM for CGM. Okay, you can go to the next one, Mika. All right, so who would be a good fit for this program? And I do want you guys to divorce in your minds patients who are eligible and are good fits versus who's going to have it covered, because those are two different things. It's basically the same kind of mental framework you have to have when you choose medications. Many patients might be a good fit for using Nurtec, but not everyone's going to have insurance that covers Nurtec. So that's exactly the same mental mindset for CGM. There are lots of patients who are really good fits, and maybe their insurance is not going to cover it, you know, or we have to jump through some hoops to get them to cover it. Okay, so eligibility criteria. We are focusing on type 2 diabetes. CGM is absolutely standard of care for type 1 diabetes. I know all of you out there take care of patients with type 1 diabetes, but for the scope of this program, which is very much RN and RD supported, we wanted to keep it pretty simple and pretty bread and butter for the scope of care for primary care. So if you do have someone with type 1 diabetes that you're taking care of and you want to manage their CGM, you can do that, but that's kind of outside of this program. You know, and you have to kind of use your professional judgment on that. Okay, so the focus for this program, where your RN and RD will be supporting the patients, is type 2 diabetes. Then they need to have one or more of the following. They don't have to have all of them, including insulin. So I think a lot of us, when we think about CGM, we think insulin, but your patient does not have to have insulin or be on insulin in order to be in this program. They might just be someone who is, you know, having difficulty with glucose management for other reasons, you know, whether that's hypers or hypos. Maybe they don't like to stick their finger, or, you know, they're just not meeting some sort of diabetes care gap. So even if they're not insulin, if they have one of those things, that is an option. I would say for most patients, the criteria that they're meeting is this third one, which is this desire to tailor lifestyle changes to glycemic control. You know, maybe they're on oral meds, or maybe they're trying to get away with not going on meds for their diabetes, and they want to see what the effect of exercising every day does on blood sugar. They want to see what cutting their carbs or counting their carbs, you know, does to their blood sugar. This is a really great tool for patient engagement in their diabetes care. In fact, if you look at the evidence for CGM in type 2 diabetes, that's really the biggest drive to use CGM, is getting patients more engaged in their chronic disease management, you know, putting more, making them feel like they're more empowered, you know, they can actually do things that affect their blood sugar. Exclusion criteria, so patients receiving care from endocrinologists, and this is mostly because these codes can only be billed out on a monthly basis by one person. You can't double dip. So if you have a patient who has type 2 diabetes and is interested in CGM and they see endocrinology, just have them talk to their endocrinologist about it, because we just didn't want to get you guys confused on the billing process. We're also excluding pediatrics for right now. CGM is actually not FDA approved in type 2 diabetes in peds right now. It is for type 1. We're excluding gestational diabetes, so any of you guys who happen to still be doing obstetrical care, MFM is using CGM for gestational diabetes, but that just seems, you know, a bit out of scope for this project. And again, because your RNs and RDs are going to be supporting it, they're not OB RNs, et cetera, we'll kind of stick to our swim lane. And again, the type 1 diabetes. You may want to work with your panel navigator to identify patients who might be a good fit. You know, I think all of us are kind of running our diabetes list. Maybe there's someone on that list that has some barriers to getting under control, and this might be a good fit for them. This might resonate with that patient. And then, you know, as always, consider your patients who are already enrolled in care management. Does anyone have questions about eligibility or the inclusion or exclusion criteria for the program in primary care? Okay, why don't you go to the next one then, Mika? Okay, so now let's talk insurance coverage, and this is where it gets messy. And this changes year to year. I mean, it's just like formulary medicine, and, you know, we are hoping that, you know, as time goes on and more patients, you know, the demand for these types of services goes up, that, you know, insurance will start covering it better. But right now, this is kind of where we are. So for commercial insurance, all you need is a diagnosis of diabetes. Doesn't matter what type of diabetes, doesn't matter in control, out of control, with hyperglycemia, without hyperglycemia, et cetera, on insulin, blah, blah, blah. If you have a diagnosis of diabetes and you have commercial insurance, CGM is covered. Now, that doesn't mean that you don't necessarily have a high copay, you know, or a high deductible plan where you're going to go pick up your sensors, and they're going to be incredibly expensive because that's your insurance, but there's no additional hoops to jump through like chart notes or DME forms or whatever if they have commercial insurance. Medicare gets more complicated. So Medicare, you need the diagnosis of diabetes. You need to be using insulin greater than TID, and you quote need frequent insulin adjustments. So that's kind of just like medical jargon that needs to go into the chart so that you know, when the prior auth team tries to get coverage, they can kind of print your chart notes and it says that, you know, this patient needs frequent insulin adjustments. We'll spend part of this presentation talking about some Epic Smart Texts we have, and a lot of them have this type of insurance language impregnated in it so that, you know, you don't have to, you know, create this on your own. It's already going to be in the note. Medicaid is the most restrictive. You need all of those three: diabetes, TID, insulin, needs frequent insulin adjustments, and you have to have asked the patient to be self-monitoring chem sticks at least QID. Doesn't mean they have to be doing that. In fact, you know, this is great for patients who are very hesitant to check their blood sugar that often, but that has to be the medical recommendation that you're having them check at least QID. So this is typically a patient, right, fasting and then prandials, right? So, you know, it is a lot, let me just say, you know, and I think one of the least favorite things, at least one of my least favorite things, is dealing with prior auths and all the headaches that come along with that. But there are some other kind of tricks out there. And I think all of us, for better for worse, are starting to get kind of good at doing this. But for CGM in general, there are usually discount vouchers from Libre themselves. So patients can call the Libre customer service line, or they can check online. I know personally I have a patient who's got Medicaid who wanted to do this, and she gets them for free because of coupons from Libre. For patients who kind of go to pick it up at the pharmacy and it seems kind of astronomically high, the pharmacist can look at, they can ask them to run through GoodRx, and oftentimes that's a lot cheaper. And I think in general, cash pricing through GoodRx is around like $37 a sensor. So it's not too bad. I think like, you know, $75 for 2 sensors, which is the full month of monitoring. So there's some tips and tricks. Additionally, I just want to mention that this is just for the device itself. The RPM codes, meaning the codes that you're going to bill out for interpretation, the codes that your RN or RD will bill out to bill their time for, you know, facilitating care for you and doing data download and you know, prepping stuff for you. That has actually been all very well covered by payers, and we've been watching the reimbursement from UWP since kind of starting to go live with RPM about 1.5 years ago. So we haven't had problems with that. It's really just getting the device. I'm going to go to the next one, Mika. Okay, so let's walk through everything that you need to do to get a patient enrolled and participating in CGM. So number one is obviously identifying patients that meet those criteria. Typically, that's going to be in clinic visits for you guys. I mean, it may be in a panel management meeting if you're kind of talking through your diabetes list, but I think in general, you're going to have live conversations with patients, you know, whether that's in a face-to-face visit or a telemedicine visit, or, you know, a follow-up conversation after you've done labs in their wellness appointment. You find out that they've got, you know, newly diagnosed diabetes, et cetera. So, you know, you'll pick your patient. After you've determined that this patient wants to participate, you're going to put in this .rpm consent, and this has all the compliance vetted consent language to enroll the patient in RPM and basically start billing for this service. We wanted to kind of mimic the workflow that we follow for like BHIP enrollment, et cetera, so that, you know, our brains don't get scrambled. But there's that .rpm consent. It's also it's a generic consent. In the future, we hope to be rolling out other RPM programs. Probably the first one that will come to life for real is hypertension. So we're probably going to start working on that program a little bit later this year. But the RPM consent is good for any RPM program. You can obtain consent via phone or e-care message. I think maybe some of you guys have gotten consent for like an e-consult, for instance, via e-care. I know I do that a lot, where, you know, maybe I get patients' labs back, they look abnormal, I want to get an e-consult, I send them a message, I say, hey, you know, your CBC looked abnormal, I'd like to get a hematology e-consult, are you okay with that? It'll get billed to your insurance. I'm like typing that in my chart, and then the patient responds, yes, I'd like to do that, rather than wait 6 months to see hematology in person, and then I order it. So similar, you could do that back and forth, but I think the majority of the time these are going to be live conversations. Then you're going to place a referral to RPM. And then there's a little drop down in the referral to RPM for different programs, and you'll choose CGM. So again, we're trying to build this with being generic in mind. So if we have other RPM programs, we can just add them to this referral, and you can just, you know, choose the different programs. But for right now, it's just going to say CGM, and then you're going to sign that referral. And then if you want to give the patient some patient-friendly instructions about what comes next, or if you want to stamp the chart with some of that insurance-friendly language to get coverage, if, you know, the PA team needs to send in your chart notes, you can put the CGM RPM enroll AVS in the chart, and it has some of that language, like this is medically necessary, patient, you know, needs frequent insulin adjustments. I recommend that they check, you know, their blood sugar, you know, QID, whatever. It has some language around that. And also it just has some language for the patient, like, you know, thank you for enrolling. This program consists of this, and you will get outreach from, you know, my clinic RN or RD, you know, et cetera. So it just has some almost like FAQ type language for the patient. And then, you know, please do CC the chart in which you had this discussion to your RN or RD, whomever is going to be helping you with this program at your clinic. And I know Sandy's not on it. German, do you happen to know if it's going to be an RN or an RD? Some clinics it's been both because they've had both. Some clinics don't have an RN, and so it's been the RD.
Yeah, primarily it's going to be our RD because we don't have an RN.
Okay.
Our RN does start next week, so she'll be in orientation and onboarding for the first month or so.
Okay, cool. So, you know, if you guys are enrolling patients, please send this to your RD then. So then your RD kind of has the whole diabetic plan at their fingertips and knows that, you know, a new referral is coming through. You go to the next one, Mika. Okay, so you consented the patient, you put the referral in, et cetera. Now you need to get the patient their materials, their devices. So for most patients, they'll have a smartphone, and all they'll need is sensors. If they don't have a smartphone, then they'll need a reader, which is basically like a glucometer. It just, you know, syncs with the sensor rather than, you know, poking your finger. And then you'll have to write scripts for both. But the workflow is almost exactly like ordering diabetes supplies. Just instead of ordering test strips, you're ordering sensors, and instead of ordering a glucometer, you're ordering a receiver. So for commercial insurance and Medicaid, this will be just like I said, it's just like a medication, type into orders, the prescription shows up, you sign it, et cetera. If you're ordering from Medicare, they need a DME form, and this comes from DME. So there are a couple things. One, they need something with your hard signature to turn into a medical supply company, and so you can use like referral to DME and then put in the stuff, or what I do for those patients, because literally all they need is something that has, you know, the name of the device with your signature, is I still put in the prescription, but I just print it instead of ERXing it. And then I print it, I sign it, I give it to the patient, and I say this needs to go to a medical supply company. You know, it's just like ordering diapers or ordering a walker or something like that for patients. There is a specific Medicare DME Libre form, and it's linked here in this presentation. It's also in the Smart Text, and again, I'll show you the Smart Text to help support documentation for CGM, but there's also a hyperlink in there. It also lives on the UWPC intranet site in the digital health. There's a digital health page. But anyway, so there are a bunch of ways you can get this, but you have to fill out this DME form and also give that to the patient. They have to turn that into the medical supply company. And just know that in general, again, for pricing, It's a little bit easier to get these from like a big box pharmacy like Costco or, CVS and Target, et cetera, as opposed to small, community pharmacies. And again, just a reminder, if they don't have a smartphone, you need to also order a reader. You go to the next one, Mika. This has a picture of the orders. So you can see on the upper left-hand side, that's the reader, if they don't have a smartphone, and the bottom one is the sensor. And, one question that I get from a lot of the providers that we're training is, how many should I dispense? And, for most patients, if this is going to be kind of their first time trying it and, they're going to be in that lifestyle camp, I probably would just give them 2 sensors and maybe 1 refill on it. That'd be enough to get them, 2 full months of CGM, because chances are, they're going to get their information that they want. They won't need to continue on it. Now, if you're managing type 2 diabetes on insulin and this is going to take the place of their glucometer readings, then yeah, you could give them, 6 with 4 refills, and that will get them through a year. If they're going to be doing this, continuously. But I would say for most patients, you're probably going to just do 2 at a time and maybe put 1 or 2 refills on it, because you're probably not going to be doing this long term for them. You can go to the next one, Mika. Okay, so what happens on the back end? So one of the reasons why we put the referral as part of the workflow is because that will go to the care management work queue, and then your RN and RD, whoever's working that work queue, will know that this has come through. So that's just like another check that this patient needs to be enrolled. It also stamps the chart for UWP, like you as the PCP are referring the patient to this program that will be billable. So anyway, so it just kind of closes the loop on a lot of things. So once your RD gets the referral from the care management work queue, they're going to do a couple of things. First and foremost, they're going to make sure that you did everything you needed to do, such as order the device. And if for some reason, I don't know, busy day, it slipped your mind, you didn't order it, then they can ping you and say, hey, Dr. Wong, you forgot to order the sensors. Can you please put that in for the patient? And you can do that. If you did everything you needed to do from the ordering provider's perspective, then they're going to reach out to the patient, introduce themselves, make sure that the patient is aware that they're getting enrolled in this program, and then they're going to check and see if the patient has been able to pick up their device. Most of the time it's just a box of sensors, but maybe sensor and reader. If the patient hasn't been able to get their stuff, they'll help troubleshoot that. Like, what does that mean? Do you have Medicaid and has it not gone through? Do we need to contact the prior auth team? Have you just not picked it up? Did you try to pick it up, but you have private insurance and it was super expensive and you're shocked and, et cetera. So they're going to help troubleshoot that. And then once everything's kind of in a row, the patient has equipment in hand, the RN or RD is going to set up their intake visit and teach them how to use their device. Go to the next one, Mika. This is just a little bit of background. I don't think I'm going to go through it because I think most of you guys kind of have dealt with the prior auth team, but just know that, they will be working it. They're aware of the form. They're aware of chart notes that need to go in. They know that, Medicare patients need to get it through DME, et cetera. So there may be some communication back and forth of which, your RD will also be a part of, but, for those who really do want to go through insurance, there is a little bit of backup for that. Go to the next one, Mika. Okay, so the intro meeting with the RN, this is predominantly for device teaching. In fact, the code that the RN or RD builds out for this visit is specifically for teaching patients how to use their device. If they have time, like if this is a pretty technically savvy patient, they'll also kind of go through the program with them, talk about diabetes goals, take some history, review your diabetes plan, et cetera. But, if you have a patient who needs a lot of hand-holding for setting up the device and, maybe using their smartphone, the RN or RD might need to schedule a follow-up appointment to kind of get through some of that teaching and reviewing of plans. You can go to the next one, Mika. And then the patient's good to go. They're kind of set free to, wear the device and send you data. Now, some of the important things that you'll have to define for the RN and RD who are going to be supporting you are obviously the clinical goals for the patient. You know, whatever interventions you're going to have the patient do, like we're starting metformin, BID, or you're going to stop eating carbs, or I don't know, you're going to start going to Orange Theory, I don't know, whatever it is, you'll define that. But you'll also want to specify some follow-up planning for your RN and RD specifically. You know, I want the patient to wear the sensor for 14 days total, and then we're going to follow up with a telemedicine visit, or, you know, 14 days total, and then I'd like the RN to check in with them, and then they'll see me via telemedicine in 4 weeks to review this, you know, etc. So just make sure that you kind of have that coordination of care information in your chart note, or have a conversation with your RD, just so they know, you know, what you want them to do. And then, you know, your support team is going to be doing this other stuff. You know, they're going to be checking in with the patient to make sure that they're wearing their device, that, you know, there's no troubleshooting. They're going to log into LibreView and pull the data reports and put them into Epic for you. Every time they do that, they're going to put it into, I think it's going to come as sometimes a TE, sometimes it might come as a CC chart if they have an open kind of message back and forth with you, but they'll attach it. They have a smart text that they're going to use that has some of the key metrics from that data report and has a hyperlink to the full AGP report. And then they'll do that typical communication that you're used to from the team. You know, how's the patient doing? Were there anything weird happened? Does the patient have questions? Does the RN have questions? You know, that type of stuff. And you'll do your typical between visit correspondence. Go to the next one, Mika. This is one new tool that we have now that we didn't have in the pilot, and this is a diabetes flow sheet. So if you go into the flow sheets tab, the first time you're in it, you'll have to search for it, and it's called the diabetes MA note. I know, really weird name. We didn't have control over that, but if you just type that and then star it, then it'll be one of your favorites. And you can see right here, this part that's highlighted in yellow. This is a way for you to look at some of the key metrics trended over time without having to kind of go a la carte into different TEs or different media tabs. So, you know, if you have a patient who's been maybe doing CGM for 6 weeks and you're having them, you know, you're having your RD get the data every 14 days, and you should have 3 GMIs, and you can look at them in the flow sheet trended over time. So anyway, so that's a view to see trends. Let me pause there and see if there's any kind of programmatic questions before we dive into AGP reports. Okay, so I'm going to do kind of quick and dirty AGP report interpretation. If you are interested in a more detailed lecture about this, then Savitha Subramanian put together a really good talk, and we have it linked in the, I think in one of the later slides in this presentation. You can watch that. She goes into very, a lot of detail about AGP reports. She shows you a few examples and teaches you how to interpret them. There's also a link to a video from Abbott that also goes through how to interpret this as a provider. But here's a quick orientation. So this is what an AGP report looks like. You can see it's divided into kind of 2 boxes up top and then a larger ambulatory glucose profile on the bottom. And we're going to kind of break this down into chunks. You can go to the next one, Mika. So this is that box that's in the top right-hand corner, and this is where we look at what's called time in ranges, meaning where was your patient, or what percentage were your patient at goal, above goal, or below goal? And it's pretty easy to kind of interpret. This bar graph is a very nice visual. The biggest one you're going to really look at is time in range, and your goal is going to be 70% or more, and a 70% corresponds to an A1C of 7%. So, you know, diabetes goals right there. And then obviously if you have someone on insulin, you'll want to pay attention, especially the hypoglycemia. And the goal is to be below 4% hypoglycemic ranges there. You can go to the next one, Mika. And then this is the top left-hand corner, And really the biggest metric here, or the most important one, is this what's called the glucose management indicator, or the GMI. And this is basically the calculated A1C from the data within this report. So this patient here had a GMI of 6.7 for these dates, February 25th, 2021 to March 24th, 2021, right there. It also has some really important metrics in terms of whether your patient was compliant in wearing their sensor or syncing your sensor. If the patient forgets to sync the sensor greater than 8 hours, you lose the data. So they have to remember to kind of scan their smartphone against their arm. So this patient right here was 98%, syncing. So that's a really good report. And this, was 28 days. We're going to go through kind of some quick tips for how to get through a report and interpret it. But I just want to draw your attention to that's where you find those metrics. You're also looking at glucose variability. Again, a little bit more important for insulin, but your goal is less than 33%. And with less variability, you lessen the risk of hypoglycemia. You can go to the next one, Mika. Okay, so here's some quick steps. So first thing is there enough data to review? And you'll want at least 14 days of data. Otherwise, it's kind of not enough data to, make any changes, which is why, when you're first initiating this with the patient and you're doing a check-in, you don't want to do it any sooner than 14 days because you just won't have enough, won't have significant amount of data. For me, when I do this, I typically do like a 1 month follow-up because it's not just about diabetic control. It's also just, how is this working for the patient? Do they have any questions? Typically I've started a new medication. I want to see if they've responded to it okay, or if they're having side effects, etc. And again, number two is, really the power of CGM in type 2 diabetes is patient engagement. And although you can interpret this on your own time and even bill out the code, not in a patient visit, really the biggest strength of AGP report interpretation is doing that together with the patient. So you can talk through patterns and, see what's really fascinating to the patient, give them a high five if they did something and, their glucose curve came down because, they're eating less carbs or something. And, reiterate, what good and bad choices do to their ambulatory glucose. When you look at the waveforms on the bottom, you'll want to make sure that you identify some key things that could trigger, highs or lows. Identify eating, identify, activity like going to exercise class. One of my patients, she realized that when she went to like high intensity interval training, her blood sugar actually spiked, and that was like kind of interesting to her. Identify sleep, identify when you're taking your meds, and have a kind of interesting discussion with the patient. Obviously look for patterns. Are your readings within range, or are there hyper and hypos, and what triggered those? And then make an action plan based on what you're seeing in the AGP reports. Like, oh, okay, you're spiking high after dinner. I think that meal's probably too big. What can we do to cut down portion sizes or amount of carbs in the evening meal, and see if we can get that down. And then you'll need to document your interpretation, and we have a smart text for that, the CGM RPM interpretation note. And if you just fill out all of the little, F2 through it and fill out all of those questions, you'll meet all the criteria to bill this out. And then I'll talk about billing in a few slides. And then please do remember to CC this chart to, your RD so they know what you're doing and if there have been any changes, and, if there's anything specific you want them to revisit with the patient during some education sessions, et cetera. Go to the next one, Mika. I think we've kind of touched on a lot of these smart texts, but this is just a slide that kind of summarizes what you might use for just the general back and forth communication with the patient. So there is a RN follow-up visit. This is what the RN is going to put on, the RN or RD is going to put on when they download AGP reports and put them into Epic. And so you'll get used to seeing that note. It's got some key metrics. It's got the hyperlink to your patient's actual AGP report in the media tab. The second bullet point is the CGM RPM interpretation note. That's what you're going to use to interpret the AGP reports. You can bill that once every 30 days. There are 2 AVSs. This is a different one. This is a treatment AVS, and this is for you to use if you're doing care plan changes for the patient. There was the enrollment AVS, which if you remember I talked about at the beginning, and that one has you know, FAQs about the program, you know, if you're newly enrolled, what to expect. It also has language, again, for getting coverage of the CGM equipment in it. And then you'll be seeing, you know, messages from your RD through my chart messages or phone call documents or, you know, CC charts just in between, kind of like you're used to for care management. You can go to the next one, Mika. This is a grid that's got all of the billing and coding codes. Really the one that you need to be interested in is just that second one, the 95251. The other ones are what your RN or RD is going to use. So that first top one, the 95249, that's for the intake note. That's for intake of the patient, teaching them how to use their device. And then the 99457 and 58, that's what the RDs are going to use to track their time. So once they hit 20 minutes, they'll bill that first one. And if they hit another 20 minutes in that 30 days, then they can build a second one. So this is just a really nice way for our RNs and RDs to get a little bit of credit for the work that they do. We want to make sure we take advantage of these codes. Just know for the providers, the 95251, the interpretation of AGP reports, that is worth 0.7 RVUs that are attributed to you. And I think most of you guys will be doing that along with your visits of some sort, so billing out your 99214 and then also a 95251. And just know, let me just also give like hot tip, this is not available in the orders tab. You have to put it into charge capture. And I know maybe a lot of you guys maybe don't use charge capture except for procedures, but that's where you find this code. I know we probably get, you know, a few questions about this every time a new clinic goes live, like I can't find it in the orders. It's like, it's not in the orders, it's in charge capture. So just kind of make a footnote for that for yourself. And go to the next one, Mika. So we have some hyperlinks for you in the next slides, but I just want to draw your attention to this all-in-one job aid. This is the CGM RPM job aid, and it has literally every single resource in it, including the workflows and also some of those resources like the billing and coding guide. So you guys might want to just bookmark this or print out a whole one. It's only 8 pages long, keep it at your desk, especially as you're learning something new. You can go to the next one, Mika. And then here are the links that I promised. There's the link to Savitha's excellent presentation. There's the link to the uwmedicine.org page that has the resources and job aids. And there's the link to the training video from Abbott that's directed at providers. So the next one, Mika. And then this is just a comprehensive list of the EPIC tools we have available. There's the consent, there's the enrollment AVS, there's the RN intake note, the RN follow-up note, the CGM interpretation note, and then there's a treatment AVS as well. So you guys might want to just keep that also, because I know sometimes it's hard to remember smart text. And yes, I know we've gotten feedback on the names, and unfortunately you can't just make short pithy names anymore because there are literally like 2 million smart texts in EPIC, and if you name it something generic, then you're never going to find it. So sorry, they're really long. Next one. Questions. That was a lot for 42 minutes. And Mika, the RDs for this phase 3, have they had their training yet?
So,
oh yeah, okay.
To jump in here. So Nikki is your dietitian. I know she's only there on Wednesdays. She has had the training. She's done some CGM starts already at the Federal Way Clinic where she works on Fridays, and she works a couple of days at the KDM clinic. So she definitely has experience. She knows how to upload the data. The only thing she doesn't know how to do are those remote monitoring code things. But in terms of training your patient and getting them started, she is good to go. My question would be for Gurman. Is she still on?
Hi, yes, I'm still here.
So Gurman, I know you guys were part of the pilot. My biggest question is, do you have the Libre View installed on one of your clinic computers? Because that's something the drivers need to get installed on a clinic computer.
I can look into that. I don't know. I know we've done it before because we had a few patients that we did it on. I can look at that. I don't know the answer to that question.
Those drivers get updated every few months. So if it's been a while, it might be, and that's maybe I'll send Nikki a note to have her connect with you when she's there on Wednesday.
Perfect.
Okay.
Cool. So, you know, from in terms of like start dates for you guys to start ordering this for patients, I mean, we're pretty much good to go. So, you know, when, you know, just start looking at your schedules and, you know, just realize that you have this tool to use. I also just want to mention, and I know we said this to Sandy and Gurman and your RDs during the leadership training we did, but we do hold office hours on a weekly basis. So if anyone has questions, you know, feel free to drop into that. Also, you know, from a clinician perspective, if any of you guys have kind of medical questions, clinical questions around it, feel free to let me know. Also, if you have any technical questions, Mika's happy to troubleshoot that. I don't think we've had any problems with the UWPC clinics, but some of the previously Northwest Hospital clinics had some issues with like the technical build, like Smart Tech not showing up or referral queue not working or something. So if you have a technical Epic-based problem, let Mika know. We can help troubleshoot it and put in an IT ticket if necessary.
And in terms of, if you guys have questions, like, you know, you can also staff message Nikki. I know she's really good at returning replies in terms of like, do I need to do a PA or is this one a DME? So she can also be an in-clinic reference for you too, in terms of if you're trying to decide what paperwork to fill out for a patient, if that is needed for Medicare or Medicaid.
Awesome. All right. Well, thanks everyone for your attention. If other questions, you know, come across your minds, feel free to reach out. And otherwise, we'll check back in to just see how things are going. Have a great afternoon and happy August.